Okay, welcome to the asbestos webinar. This is webinar 2 of the series of 3, spearheaded by Alec Farquhar, and I'm leading this webinar. So this one's on risk management and advocacy. I'm the lead, the host. I'm also going to be timekeeper. We have a fairly tight schedule, so if I can ask all of the speakers to try and keep to the time frame. And just welcome everyone, and thanks for joining. First, just want to give a land acknowledgement. I would like to begin by acknowledging that I'm speaking from Ottawa, Canada, to all First Nations, Inuit and Métis people and their valuable past and present contributions to this land. As I am in Ottawa, I am located on the unceded territory of the Anishinaabe Algonquin Nation. The first webinar where Alec was the host is now available on YouTube, so you can actually go and see that. And I highly recommend it. It was an amazing webinar. Just did a bit of a look at all the different countries that have registered. We have more than 500 registered and 60 countries represented so far. The strategic framework, I've just put that up. We're not just about workers, we're also about families and communities. We want to prevent work-related disease, especially for underserved populations. And we are all volunteers. We do this in our spare time. We're kind of very busy really doing a lot of this. So it's almost like having a second job. I just want to put in this, we're kind of trying to get support. So Tuan Nguyen's going to be talking about this as well. The conference that we're trying to get support for, sponsorship for, being held in Vietnam. So the idea is to try and distill all of the information from these webinars into this conference. And WHWB International is also going to be transferring funds for this. So there's going to be a lot of people on the call here that are linked to multinational companies and perhaps can source funding, but we would really appreciate if you could help sponsor this conference as well. I just kind of a quick overview. I'm giving you the introduction. We've got Dr. Marcus Orellana. We're very grateful for Dr. Marcus Orellana from the United Nations to speak. We've also got Emil Tompa from the Institute of Work and Health. I'm going to give a bit of an update from Barry Castleman and the ILO. That we couldn't get representatives from them, but they have provided some information. We're very grateful to have Dr. Christine Oliver present on medical surveillance. And there's a new organization called Asbestonomy, which and we have somebody, Mathilde Landry, who's going to be talking about this organization. I think probably the best thing to do at the moment, I can carry on with my slides, but while we have Dr. Marcus Orellana, my thinking is that I just hand it over to him first, and then I can carry on with the rest of the agenda. Is that okay with you, Dr. Orellana? Are you okay to speak now?
Okay. Thank you very much, Kevin, and thank you for the invitation to join this conversation. My name is Marcos Orellana. I'm the United Nations Special Rapporteur on Toxics and Human Rights, and I'm joining you today from Washington, D.C. In these few minutes, I intend to speak a little bit about the mandate for those of you who are not familiar with it, and explore some possibilities that may arise in regards to the subject matter of your work. And then I was also asked to address the Rotterdam Convention on International Trade in Hazardous Chemicals and Pesticides. And so I will do that as well. So jumping right into it, the United Nations Human Rights Council has conferred upon me a mandate to monitor and report on the situation in respect of human rights that arises for people that are exposed to hazardous substances and wastes. This mandate was created back in 1995. At the time, the African group in the United Nations was particularly concerned about the dumping of hazardous wastes in the African continent. Most of these wastes were generated in Europe. Let's recall that at the time, Europe had been strengthening its chemicals and wastes laws. And for many companies, that meant that the path of least resistance to deal with the hazardous waste was to put them on a vessel, on a ship, send it over to Africa and dump it there. The modus of operandi was very similar in every case. There was a northern company making an agreement, a contract with a company, a southern company in one of the African states, whereby the African company would receive the waste and represent to treat it properly, but capacities were lacking, and so this use often ended up being a sham. And in the end, the waste got dumped, and this affected the health and territory of African nations. This was decried as an example of environmental racism, global environmental injustice, a practice that needed to end. And the rest of the developing world very much supported this because cases were proliferating in various parts of the world. The cases of hazardous waste dumping. Now, as you can imagine, and as you can already see, the mandate was born out of a very controversial situation. So it was the South pointing fingers at the North. It was a mandate that was born out of a vote. And so the Northern countries that voted against it were doing everything they could to undermine the mandate. That meant ignoring it, making statements against it, trying to defund it, and so forth. All of that began to change back in 2011, when the mandate was reframed and renewed by consensus. And I want to point this out, that the renewal of consensus changed the political dynamics around the mandate, toxics and human rights mandate, because it was no longer a vote. It was no longer finger-pointing exercise. Now it became a partnership for the international community. That was at the Human Rights Council. The predecessor of the council was the Human Rights Commission of the United Nations that was heavily criticized for having become politicized, for having members that were not among the human rights observers of the world, dictatorships and mass atrocities and so forth. What's important in this renewal is not only that it was achieved by consensus, but that the mandate was reframed. And I want to also underline that, because if in its origins, the mandate was focusing on hazardous wastes, the mandate as reframed and renewed by consensus is now focusing on hazardous substances and wastes. So chemicals and wastes, for short. The life cycle of chemicals from production, even before that, extraction, production, consumption, disposal, and all of that, possibly in a circular economy approach. So this is, of course, a very big change, because it opens a multitude of opportunities for the mandate to engage a number of issues, as the mandate has done since, including the issues that are of concern or of particular concern to the audience here, such as asbestos. So the current focus of the mandate is precisely that: a circular economy, a comprehensive life cycle approach to chemicals and wastes. Now, that is a broad universe, and in order to bring in a level of specificity and focus, this is where the human rights-based approach comes in. So a human rights-based approach will look at reality from the perspective of people who are marginalized or disempowered or vulnerable, or from the perspective of those in society who suffer the most from exposure to hazardous substances and wastes. That is one reason why the mandate is preparing thematic reports. I'll get into the tools of the mandate in a second. Thematic reports on the interface between toxics and people that may find themselves, or groups that may find themselves in vulnerable situations. So in order to describe that strand of work better, take a couple of minutes to talk about the tools that the mandate has at its disposal. So as a mandate of the Human Rights Council of the United Nations, it reports to the Human Rights Council once a year in Geneva. I'll be heading to Geneva in September to participate in the Council's session scheduled for that time. And I report also to the General Assembly of the United Nations, and that is taking place in October. So these reporting moments through these organs of the United Nations are important because they bring the international community together in discussing what are particularly important issues in respect of hazardous substances and the enjoyment of human rights. So it is a monitoring and reporting mandate. These are the crucial moments of report. They provide also for an interactive dialogue where civil society can participate. Interventions from NGOs are very useful, very important in putting the finger also on the pulse of the issues that are of most concern in the field. States take the floor as well to voice their concerns about the various issues that are being discussed and presented. So this is a moment of dialogue, of an opportunity for dialogue in respect of these issues. So this is an important tool. And in addition, the mandate prepares thematic reports. These are reports that look at a specific issue in detail. And so, for example, the last reports that I've prepared, they focus, for example, on indigenous peoples and toxics. This is building on what I was saying earlier about the human rights-based approach. Indigenous peoples worldwide are on the receiving end of hazardous substances and wastes, often compromising their health, their livelihoods, their cultural rights, and other internationally protected rights. I've also put out a report on the right to live in a non-toxic environment that looks at the proliferation of sacrifice zones around the world. So these are areas that are so heavily contaminated, so polluted, that they represent a denial of the right to a clean, healthy, and sustainable environment. People living in these places are left voiceless, exploited, and sacrificed, often in the name of profits of the companies that operate their facilities in these locations. Similarly, I produced a report on the right to science, which has been the distant cousin, perhaps, in the human rights family, a right that is often forgotten, but that requires alignment, among other things. It requires alignment between policies and the best available science. Now, we see that in regulatory frameworks around the world and also internationally, there is a misalignment, and this misalignment is not an accident. It is the result of deliberate disinformation and misinformation by vested interests. These are some examples of thematic reports. There are other examples, such as in respect of plastics and human rights that, among other things, help push the needle towards an international negotiation on an international legally binding instrument on plastic pollution. That negotiation is ongoing, and the challenge there is to inject a human rights-based approach into the design of the treaty so that it can be legitimate and more effective. It can actually solve the problems that it is intending to address. And of course, there's a recent report on mercury and small-scale gold mining. As we know, mercury is a persistent, very hazardous metal. It bioaccumulates in the environment, in the food chain, and the largest source around the world of mercury to the environment is small-scale mining. The Minamata Convention is the most recent multilateral environmental agreement that's been negotiated. It's a comprehensive, it's a robust agreement, but yet when it comes to small-scale mining, it is failing. It has gaps and shortcomings by design and application that really need to be closed. So this report, thematic reports, puts the emphasis on that. So this is an example of one of the tools that the mandate uses to carry out its work, the thematic mandates. Another tool are country visits. And so, for example, during the decades of the mandate, it has visited numerous countries. I'll be heading to South Africa in a couple of weeks. If you have information that you think is relevant for my visit, please visit the mandate's website. It was in the slide that Kevin put on screen a moment ago. There's a call for inputs. All inputs are welcome. They're very useful in designing an agenda and also scoping out issues. I'll be heading to Australia later on in the year, towards the end of August, the beginning of September. Mandates carry out, for the most, 2 country visits a year, on official country visits. But we can only go to those countries that have invited us and have confirmed the dates. So there's a lot of steps that need to be put in place before a mandate can actually visit a country. In the recent past, I had an opportunity to visit Ghana, Paraguay, Italy, and the island of Mauritius. I mentioned Mauritius in particular because there the issue of asbestos came up, and you can find references to that in my country mission report. All of this information is available on the mandate's website. So just before giving a couple of minutes presentation on the Rotterdam Convention, I thought I'd mention that one last point about the mandate's tools are communications, and those communications are, in a way, casework. So situations, cases where individuals, where peoples, groups, communities may find themselves under abuse by a company or by a government in respect of their rights to life, health, physical integrity, or their rights to water, food, the right to a clean, healthy, and sustainable environment, as they relate to the exposure to hazardous substances and wastes. The mandate routinely sends letters, allegation letters, and other letters to governments, to companies in respect of such situations. Just to mention a couple, letters sent to Sweden and to Boliden, a company in Sweden, for hazardous wastes transported and dumped in the Atacama Desert in northern Chile, in the city of Arica, and the public health tragedy that has unfolded in that city. Letters sent to the United States of America for the environmental racism in Louisiana, in Cancer Alley, in the petrochemical complex there. Letters sent to Switzerland in regard to the lack of effective control over gold refineries that are actually fueling the demand for human rights abuse tainted gold. around the world. There's many more examples of letters and casework involving human rights violations and abuses, well, allegations thereof, sent to governments and companies. But I think I'll keep that summary short. You'll find more information on the website. So that's it's a flavor of what the mandate does. There's more to it, but perhaps the Rotterdam Convention is that's a good bridge to speak about the Rotterdam Convention, because there my predecessor, working with a number of organizations active in that space, they came up with an idea to overcome some of the deficiencies that have become apparent in the operation of the treaty. In my current tenure, I've supported that process, put out statements, public notices, intervened in the discussions at the conference of the parties of the instrument. So this is a flavor of what the mandate does. So with that, why don't we move towards the Rotterdam Convention, and after that, perhaps there may be questions, and I'm happy to take some questions if the organizers agree that that's a good idea. So the Rotterdam Convention dates back to 1998. Some of its antecedents before the Rotterdam Convention was in place, the UN Environment Program was beginning to experiment, I'll say it that way, with guidelines that provided for prior informed consent in respect of shipments of industrial chemicals. So this was, I would say, the first time that the international community was coming to grips or trying to do something in respect of the thousands of hazardous industrial chemicals, including pesticides, that were entering international trade. This is in the family of multilateral environmental agreements in the chemicals and waste cluster. There are only a few. The first one is in time is the Basel Convention on the Transboundary Movement of Hazardous Waste. This instrument provided for a mechanism of prior informed consent in order to control transboundary movements of waste. Those negotiations were very controversial. This mechanism of prior informed consent was labeled as a legalization of the international trade and dumping of wastes. The African group, many in the global south, wanted a total ban on the exports of hazardous waste from the global north to the global south. That ban eventually was introduced in the convention. It wasn't in the original instrument, so this became a very, very contentious issue. Now, this is where the model was taken from, but the Rotterdam Convention takes the model and weakens it in a number of ways. So for that reason, many observers, well, at least some, they have pointed out that the prior informed consent mechanism of the Rotterdam Convention is not really a PIC mechanism, because there are so many exemptions and exclusions and exceptions that at the end of the day, it is a very weak mechanism. But before jumping too much ahead into the criticisms, these were some of the antecedents back in the day in regards to the negotiation of this convention. So the guidelines that UNEP had put in place, the Basel Convention that was in place in regards to wastes. During the negotiation, there were various positions. The European Union had in its internal community order legislation requiring prior informed consent. The G77, however, wanted a total ban on certain hazardous chemicals of industrial use and hazardous pesticides. Now, that position did not prevail, and instead, it is focused on consent. And what this means is that the Rotterdam Convention is not an instrument that will phase out or ban or even regulate the use or production of hazardous industrial chemicals or pesticides. All it will do, and so it's very limited scope, all it will do is establish a system of shared responsibilities where the exporting country will communicate certain pieces of information to the importing country so that the importing country may be in a position to decide whether or not to allow the import of that shipment. So the notion of shared responsibilities is one of the key characteristics of the agreement, and the notion of information. So now this relates to the right of information in human rights law. It also relates to to what we're seeing in so many parts of the world, lack of capacities in dealing with hazardous chemicals and wastes. And so the countries that benefit the most from this instrument are developing countries that lack the capacity to know what are the risks and hazards associated with certain industrial chemicals. With respect to a certain list of chemicals, again, to restate the point, the convention requires that the exporting country transmit information to the importing country prior to the shipment of a chemical, and only if the importing country consents to the import, then the operation may take place. Now, that's the theory. There are so many loopholes that, again, commentators have pointed out that this doesn't work in practice very much. So characteristics, again, to restate: shared responsibilities, information, and a third one is the science policy interface. And I want to stress this because the convention is not static. In order for it to function effectively, there needs to be a mechanism whereby new chemicals, or rather chemicals, are listed and controlled. Now, new to the convention, it's not necessarily that they are new as in synthetic chemicals or new to the world. So the convention will control those chemicals that are listed. In order to make it to the list, that's where the science policy interface comes in. Now, unlike other agreements, the process for listing a chemical is rather convoluted, and it rests on various pieces working together, and we're seeing that they're not working very well. Now, that may be an understatement, but let's see how the process worked. In order for a chemical to be listed, the convention relies on what it calls final regulatory actions. So if a country decides that a certain industrial chemical or pesticide is hazardous or risky and will control its use or even ban it, that's a final, can be an example of a final regulatory action. And that needs to be communicated to the convention. When the Secretariat has a compilation and there's mechanisms for sharing this information. If another country comes to that same conclusion, another country in a different region, the convention identifies various regions, so it gets convoluted. So you have one country in one region, another country in another region, both countries agreeing in a way, or both countries adopting in their internal regulatory spheres, regulatory action in respect of a given chemical, communicating that to the Secretariat, and then this will bring this chemical to the attention of the convention. That's where the chemical goes under review by a chemical review committee. So this is a scientific body. It's experts nominated by governments. It will conduct an analysis of the chemical in question, and it may recommend, if it satisfies the stringent criteria that are established in the convention for listing, it may recommend the listing of that chemical in so-called Annex 3, which will then make it subject to the control procedure of the convention. This is all quite
Dr.
convoluted.
Amar,
I
sorry,
hope I'm not losing anything.
Can I kind of just interject slightly?
Yeah.
We have another speaker, Emil Tompa from Institute of Work and Health, talking about the economic burden to Canada, and we have kind of a tight agenda. There is a question in the chat box about what is the mechanism for an invitation for inspection in a country. Can an NGO complain, which can lead to an inspection? I'm just wondering in a minute, would you mind answering that question? And then I'm sorry to kind of move it on a bit, but we have we have a lot of speakers. What your mandate is very important. It sets the scenes for all the countries. It's the framework. So we just really wanted you to introduce yourself. But just with that question about the mechanism for an invitation for an inspection of country, and also, you know, how important is asbestos within the mandate? Like, do you look for asbestos in just about every country you go to, or is that depends on what's asked?
Yeah, thanks, Kevin. So I was elaborating on the Rotterdam Convention by request of the organizer. So just to wrap that up, then the point is that the listing of the chemicals is not working very well, at least. It's not working with respect to asbestos. It's not working with respect to paraquat. And so attempts at overcoming this breakdown in science policy interface are not succeeding because of a veto that has been effectively applied by certain countries. So I'll leave the Rotterdam Convention there and then move on to the question. I'm happy to take the questions. The mandate on toxics and human rights is open to communications, to requests from any person, any NGO around the world. It is a global mandate. Now, when information is presented to the mandate, there will be a process of fact-checking. If warranted, a letter may be sent to a country or a company in question. So that's, in a way, the genesis of communications to companies and to governments. In respect of country visits, anybody can request the mandate to visit his or her country, but the mandate can only visit, as I mentioned, those countries that have officially invited the mandate and confirmed the dates. And so if somebody feels that the issues that they're working on need further attention, one way of trying to secure a visit by the mandate is to connect with the Foreign Affairs Ministry and other ministries relevant in the country to get those invitations sent. When a mandate visits a country, there will be a scoping exercise to identify what are the priority issues in respect of chemicals and wastes. This exercise involves, for example, sending out a call for inputs, as I mentioned in respect of my forthcoming visit to South Africa or also to Australia. These inputs are very important. That's where NGOs and others will have an opportunity to present their views as to what are the most important issues in their country. And based on that, the mandate will put together an agenda and conduct country visits. That's where asbestos has come up in regards to a couple of countries. I think that's the questions that were presented to me. Thanks, Kevin, for the invitation, the opportunity to be with you all. I invite you and encourage you to visit the mandate's website, to follow the mandate on Twitter as well. And so again, have a good day. Thank you very much.
Thank you very much, Dr. Orlana. And your hyperlinks will be on the slides that'll be on our YouTube channel as well. So all of this information will be recorded, and also the introductory slides and the information, the links will be on the slides for everyone's benefit. So we really appreciate your time. Without further ado, and I just want to kind of keep to time here, and I won't actually go through Dr. Tompa's bio because it's kind of long. And we really want to hear what Dr. Tompa has to say. It is actually on the introductory slide. So I might just hand it over to you, Dr. Tompa. We're really grateful for you to present.
So thank you very much for this opportunity to present this work that I've undertaken with colleagues at the Institute for Work and Health and the Occupational Cancer Research Center, both of which are based in Toronto, Ontario. And so I have the team of people who are working on this with me. They're listed at the bottom of this slide. This study was undertaken in between 2015 and 2017, and the publication that has followed from this work is listed in that link there. It's an open access publication, so anybody can access the details of this study. I'm going to really obviously be giving a very high level overview of it in the 10 minutes that I have allotted to do the presentation. Let's just move to the next slide. So what I'm going to cover is just a little bit of the methodology, not too much. I don't want to bore people with all the mechanics. It's quite an extensive piece of work that we did over a period of 4 years. I'll really focus on the study findings and the research impacts that have followed as a result of this work and the work we're continuing to do from this initial body of work. It was part of a larger project where we were looking at occupational cancers in Canada to identify both the human burden as well as the economic burden in different sectors, but in different regions of Canada over an extended period of time. So this is one of the first modules of work we did looking at occupational asbestos exposure. So in terms of the methodology around the epidemiologic component, this is not my work. This is the piece of work at the front end that was undertaken by the Occupational Cancer Research Center. So I'll just speak to it at a very high level because it's quite detailed, and some of it which even I don't quite understand because it's quite extensive work where they took labor force size by province in Canada, sex, age, and industry, and they identified these numbers from 1961 right through to 2001 to estimate the level and duration of exposures, as well as survival probabilities through to 2011. 2011 is our reference year for the study, and we chose 2011 because that was the most recent census year at the time of our analysis, which, as I mentioned, we were doing between 2015 and 2017. So from that numbers, then they tried to estimate the number of cases that would have arisen, newly identified cases in 2011. So another key component of this work is estimating, or developing estimates for the attributable fractions and relative risks based on extensive literature synthesis that they undertook to get the best estimates based on the knowledge base that was already developed up to that point. And then the last part of the epidemiologic component was to estimate the number of cases, newly identified cases that would have arisen in 2011 that are attributable to occupational exposures. We also looked at para-occupational exposures, that is family members who might be exposed through a family member who works in a sector where there's asbestos exposure. They bring it home maybe on their clothing, and then a family member may be exposed as well. So we looked at para-occupational exposures. And those numbers for the newly identified cases in 2011 were identified by province, sex, age, and industry. So that's the epidemiologic component to it. And then the next piece is obviously the economic component. And that's the part that myself and my team here at the Institute for Work and Health undertook. So we took those newly diagnosed cases from 2011 and looked to identify the total lifetime cost of cases incurred by all stakeholders. We wanted to do a societal level economic impact analysis. So we're looking at the individual, family unit, the community, and then more broadly, the employers, society, overall productivity losses. There's quite an extensive roster of impacts in terms of the economic component that we calculated, and I'll provide more details in the subsequent slide. But in terms of at a high level, the kind of buckets of impacts that we were looking at were the direct costs. So direct costs are the immediate healthcare services that are required to treat that case over the remaining lifetime of that individual. The indirect costs were about output and productivity in paid employment. So lost productivity because the person can no longer work. Looking also at other productivity implications in home production, all of the lifetime productivity losses associated with that case. And then the third component, the high level bucket of it was about quality of life costs. So this is about social role engagement and the intrinsic value of health. So those are the three broad categories of impacts that we were looking at. On this slide, I've broken it down with a little bit more detail. I'm not going to walk you through all of these, but the direct costs are the green at the top level. I'm looking at the individual, the family and community, the employer, and the systems and public sector, which all together aggregates up to the societal level. The indirect costs are in black. That's a middle component. That's most, as I mentioned, about productivity losses. And then the third component is that the individual component. It's about quality of life, is a loss of opportunities to engage socially and intrinsic value of life. A lot of that may be morbidity. Some of it may be premature mortality as well. So the two are put together into that quality of life. And as I mentioned, we're looking at the societal level. So we're aggregating individual, family and community, employer, and the systems and public sector level impacts. As we do this aggregation, just want to point out, we make a strong point of not double counting. Some things may surface at multiple levels, and it may be the same items such as productivity losses. We want to make sure that we're only counting at once. So in the aggregation process, we try to remove any kind of double counting that we are aware of. So here are our findings for the economic burden of mesothelioma. Our epidemiologic team identified that there were 427 newly identified cases in that year attributable to occupational exposure. We see the direct costs at the top in green, and then the middle part is the indirect costs, productivity and output losses, and then the last part of it is health-related quality of life costs. And as you can see, we've calculated the cost for all 427 cases at the societal level. We have the aggregate at the bottom in blue here. And then we did it on a per case costing as well. So it's just over $1 million per case. And just to highlight some of the proportionality of these impacts. So as you can see, 61%, so quite a substantial portion of the total economic impact is about health-related quality of life. This is morbidity, as I mentioned, and loss of life expectancy as well. So both morbidity and time are included in that. And then the next second largest impact is about productivity and output losses. So the 25% is associated of the total cost is associated with that component. So as you can imagine, the remaining part is the smallest part. So the direct costs, the healthcare costs are the least expensive. And it's interesting to note that, because that is often what is focused on when we do these kinds of systems level analysis, and we're only capturing the tip of the iceberg when we look only at the healthcare costs to the healthcare system and maybe out-of-pocket healthcare costs as well. Next, then we have the economic burden of asbestos-related lung cancers. Broken it down in the same way: direct costs, indirect costs, and quality of life costs. Here we have 1,904 cases identified, newly identified cases from 2011, for a total cost of over $1 billion, almost $2 billion. And then per case costs are just under $1 million. And here too, we find that a large part of that impact is about health-related quality of life loss. And the second largest impact is associated with productivity and output losses. So the indirect component of it is 27%, and quite a smaller proportion of here compared to the mesothelioma impact is attributable to healthcare costs, largely because the healthcare costs are a little bit less for a lung cancer case than a mesothelioma case. So again, important point here is that the healthcare costs are just the tip of the iceberg, and a large part of that impact, that burden, comes from indirect costs and quality of life costs. So in terms of summarizing the findings from this study, the total cost of mesothelioma and lung cancer from asbestos-related occupational exposures and para-occupational exposures for new cases in 2011 was $2.35 billion. The per case cost on average for these cases is about $1 million. As I mentioned, the health-related quality of life costs are the largest proportion of the costs at around 65%, and the direct and indirect costs are about 35% of that impact. So as you can see, there's a substantial economic burden from those 2,331 newly identified cases in 2011. So that is just 1 year's burden from new cases. And this is likely an underestimate of what we saw in the subsequent years. We didn't do calculations for subsequent years because there was increases in the number of newly identified cases in the years following 2011. So this yearly impact, was likely increasing over the years following 2011, given that fact that we had more cases arising in those years. In terms of what this study adds, this was the first published economic impact study on occupational cancers attributable to asbestos exposures. It's quite comprehensive. We looked at, as I mentioned, the societal level impacts. These findings provide really important information for policy decision makers in terms of priority setting, in particular, the merits of banning asbestos in countries where products with asbestos are allowed. And it actually was used in Canada for that purpose. And in the next slide, I'll talk a little bit about that. The case costing itself can be used as an input to economic evaluations of exposure reduction efforts. And we've actually used it that way ourselves. And subsequent body of work we did from this was looking at the economic evaluation of initiatives to reduce exposures. And as I mentioned, this body of work was not looking just at asbestos exposure, but other occupational cancers as well. And we have been doing studies where we're using these case costing to do the economic evaluations of the cost benefit of initiatives to reduce exposures. So the methodology provides a really good platform for economists for future economic burden studies and societal level impacts of occupational exposures to reduce these efforts through promising practices going forward. In terms of some of the output that was produced and for a broader audience, the CAREX is an organization based here in Canada that produces some brochures from this work, and I have a kind of screenshot of one of those brochures where they're highlighting the 1,900 lung cancer cases caused by workplace asbestos exposure in calendar year 2011. And they also profiled the economic burden or impact at $2.35 million as we've estimated. The other really important item that followed from this was the use of our work to do regulatory impact analysis for the federal government. It happened to come out at a very opportune time when Canada was introducing, and it has done that, a ban on import of products that include asbestos. And so they require at the federal jurisdiction level to do impact analysis of any kind of regulations. That's essentially a cost benefit analysis. So they need to show that the benefits outweigh the cost to society. So they used our case costing to do that impact analysis of those new regulations. And they were really pleased that we had done a lot of the legwork to get the case costing so that they wouldn't have to do that because it's a substantial undertaking. So they were really giving us a nice kudos about all our good work that we had to make their work easier to do that impact analysis. So this is just a quote from one of the people working for the federal government that came forward and commented on how helpful it was for them to do their work based on our precedents. So, and then I'll just leave it open for any questions if we have time for that, or any other comments about this work. And Kevin, I think you're muted.
This is amazing work, and I just want to say we've kind of got a few other speakers. We're just really grateful for you to share this model, and the only thing I can suggest at this time is there may be some people here that have access to economists, and they might be doing this kind of work in their respective countries. Would it be possible, like if they could reach out to you in the future, if they're going to listen to this presentation and look at the slides, but if they have more questions, could they reach out to you and maybe ask you questions?
Most certainly, definitely. My contact information is on the last slide, as well as the link to the actual open access article. So definitely would love to entertain any kind of conversations we can have. It only works when we all work together to make headway on doing a good job of the measurement and evaluation of these kinds of issues.
Great, thank you very much. I just think because we've got Dr. Christine Oliver there, and we're probably 10 minutes behind time.
Okay, well, thank you so much.
Just hope you can stay, and we've got a Q&A session at the end, but we really appreciate your time, and it's such important work. Thank you so much. So over to you, Chris. I do have, like I said, I have people's bios on the slides, and you can actually find out a lot more about the speakers when you do look at the slides. But for the sake of time, I think I might just hand you over to Chris, and maybe Chris could just quickly introduce herself and then present her information. Thank you, Dr. Oliver.
Good morning. I am happy to be here today to talk to all of you about medical surveillance and asbestos-related disease, the importance of medical surveillance. So again, I'd like to introduce you to Dr. Ramazzini. And in 1713, in his treatise De Morbis Artificum, he wrote, "We may be sure that there are many things in general use that are supposed to be harmless because they introduce their poisons gradually and with stealthy foot until some accident plainly shows their hidden harmness." We have had many accidents with asbestos, and its hidden harmness is manifest. Next slide, please, Kevin. The Encarta World English Dictionary defines medical screening as a test or testing carried out routinely on supposedly healthy people in order to establish as early as possible whether or not an illness or disease is present. OSHA, the Occupational Safety and Health Administration, states screening tests are usually administered to individuals without current symptoms, but who may be at high risk for certain adverse health outcomes. Next slide, Kevin. Medical surveillance, on the other hand, is continual observation of a person or group. OSHA states about medical surveillance, surveillance may be based on a single case or sentinel event, but more typically, surveillance uses screening results from a group of employees to look for abnormal trends in health status. Next slide. The ultimate goal of medical surveillance and screening, of course, is prevention. Secondary prevention, the avoidance of unnecessary mortality and morbidity by early detection and removal of the offending lesion if possible, which it often is in the case of lung cancer. Tertiary prevention, which is reduction of the severity of persisting lesions by treatment, and as treatment for both malignant and non-malignant asbestos-related diseases evolves, tertiary prevention will become more important, I believe. Medical screening and surveillance is, of course, key to primary prevention. It provides information that makes the case for elimination of exposure. Next slide. An international meeting of experts in Helsinki in 1997 identified 4 goals of screening in the case of asbestos-related disease. Identify high-risk groups, target preventive actions, discover new occupational diseases, and aid in the development of improved methods of treatment, rehabilitation, and prevention. Next slide. Medical surveillance is a stepwise process. Step 1 is to identify the target population. The principal determinant is risk for disease. In the case of asbestos-related disease, risk is dependent on dose and latency. Dose, in turn, depends on duration and intensity of exposure. Sources of information that inform our understanding of risk include air sampling data, the occupational history, standardized questionnaires that then feed into a job exposure matrix, epidemiologic studies, and disease registries. Next slide. Step 2 is selection of the disease outcome of interest or focus. That is the disease that you want to screen for. Step 3 is design of the surveillance program. Both of these depend on the existence of an effective screening tool and or a coherent rationale for screening. Important is necessary is the determination of feasibility of the surveillance program or the screening program. Is a support structure in place? Are intervention tools available? What are the institutional capabilities for backup? What are the educational resources? Next slide. Step 4 is the implementation of the surveillance program. This involves the education of stakeholders. There must be informed decision-making. Social and professional support structures must be in place. Participants must have physical accessibility to screening. Appropriate medical specialists must be available for follow-up, evaluation, and care. And then finally, where possible, the surveillance program or the screening program should be piloted. Next slide, please. Asbestos-related diseases are non-malignant and malignant. Non-malignant diseases are asbestosis and pleural disease. Malignant asbestos-related disease includes lung cancer, malignant mesothelioma, cancer of the larynx, cancer of the ovary, and gastrointestinal cancers. Among these, only lung cancer and gastrointestinal cancer, specifically colon cancer, have proven have methods of screening that have been proven to be effective. Next slide. I'd like to just get into the weeds of lung cancer a little bit as an example of an asbestos-related disease for which we have been able to screen effectively, and that is lung cancer. Lung cancer is the most common cancer worldwide. Lung cancer accounts for the vast majority of occupational cancer deaths globally, with a population attributable fraction of 17.6%. Asbestos is the most common cause of occupational lung cancer, and yet asbestos-related lung cancer remains a largely unrecognized health hazard. Low-dose chest CT scan screening has been shown to be effective for lung cancer, reducing lung cancer mortality by 20% or more. Next slide, please. Some history about low-dose chest CT screening for asbestos or for lung cancer, period, and also for asbestos-related lung cancer. In 2011, the results of the National Lung Screening Trial conducted in the US showed a significant increase in risk for lung cancer mortality. Risk factors in that study were age and smoking, including both pack years and abstinence. A year later, the American Association of Thoracic Surgeons published guidelines for LDCT screening for lung cancer, adding to the age and smoking risk factors used by the NLST, occupational exposure to lung carcinogens, chronic lung disease, including COPD, family history of lung cancer, and personal history of cancer as second-tier risk factors. Delva et al. In 2017 published an interesting examination of occupational exposures that, together with smoking, bring lung cancer risk to a level that approximates or exceeds that of the NLST risk to facilitate implementation of lung cancer screening programs. Barboni et al. In 2018 published the results of a study of an asbestos-exposed cohort offered low-dose chest CT scan screening. Maisonneuve et al. In 2019 published the results of a study using nested case control analysis and meta-analysis of LDCT screening of asbestos-exposed groups to assess the value of low-dose chest CT scans in lung cancer detection. And these were two of the earlier published studies looking at asbestos-exposed groups. Next slide, please. Barboni et al. In their study, they examined a cohort of over 2,000 asbestos-exposed men who were enrolled in an occupational health surveillance program in Northeast Italy. Low-dose chest CT scan screening for lung cancer was offered. 926 cohort members participated. About 1,500 did not. Standardized mortality ratios comparing the cohort to both regional and national data showed a decrease in lung cancer mortality that did not reach statistical significance. Comparing the screening participants to non-participants, hazard ratio for lung cancer showed a statistically significant decrease in lung cancer mortality among those who were screened. The authors concluded that their results support low-dose chest CT scan screening and surveillance of asbestos-exposed workers. Next slide. The Collegium Ramazzini in November of 2022 completed its draft of a statement, a collegium statement for occupational lung cancer screening. The statement recommends for persons at risk for occupational lung cancer, annual low-dose chest CT screening for those who meet the following criteria: 50 years of age or older, 10 pack years of smoking or more, and 5 years or more of work in an at-risk occupation, with adjustment based on the intensity and frequency of exposure. Next slide, please. The Collegium Ramazzini statement is important, I believe. It was written by Collegium Fellows with many years of relevant experience representing a diverse group of stakeholders. It takes into account a wide range of needs and circumstances as its focus is global, and it is based upon an extensive body of relevant published literature. Next slide, please. In conclusion, medical screening and medical surveillance are intertwined. They are not identical. Medical screening is oriented towards the individual. Medical surveillance is oriented towards groups. Both have the same goal, however, and that is prevention. The most important consideration when embarking on a screening program or a surveillance program is proven efficacy of the screening to be undertaken. It's past time for medical screening and medical surveillance for occupational disease to be brought into the 21st century. It took some time for screening for lung cancer in asbestos-exposed individuals to come to the fore. I thank you for your attention. Sorry for the technical difficulties. Thanks, Kevin.
We really appreciate you condensing such important information into such a short time frame, and I'm sure that many people around the world on this call will really benefit from the information you shared, Dr. Oliver. Thank you so much. And I just want to say it's so important that occupational hygienists work closely with occupational physicians, because this kind of surveillance does feed into prevention. That's a really important point. Thanks again. So we might just move on then we do have somebody here from a organization called ASBESTOnomy, Mathilde Landry. Did you want to just quickly introduce yourself, Mathilde, and just share a bit about ASBESTOnomy? We're a little bit, we're trying to catch up in time, so if you could kind of keep it quick, that would be great. Thanks, Dr. Oliver.
Yeah, sure. I will be quick. So hello, everybody, and thank you for welcoming ASBESTOnomy today. So ASBESTOnomy is an organization that started in France 2 years ago. We created ASBESTOnomy because we realized that in the asbestos ecosystem and market, there is a lot of association on asbestos for asbestos victims, and a lot of national organization for occupational hygiene in general, but there is no organization and specifically on asbestos, and that allow industrial professionals to be related with asbestos association, asbestos victims association. So we wanted to create an organization to allow each industrial group or professional in asbestos market to have access to this association directly and to learn from them. So we created Asbestonomy with the goal to allow knowledge sharing around asbestos, whether it's on asbestos disease, like we learned just before, or asbestos market in developing countries. So we wanted to create a global organization on many topics to allow people to learn more about asbestos and what is going on in the world for asbestos related subjects. We also wanted to improve asbestos management practices around the world. That's why we created an organization for all the countries around the world and not only a national organization, because we think that each country can learn from another country to improve the management practices on site. And of course, we want to reduce asbestos exposure in the world. So we created that organization with the ultimate goal to participate to the reduction of asbestos exposure in the world. So what we have done so far is that we organized 2 events. And I didn't mention it, but we are not looking to earn financial benefits with that organizations. So that's why when we organize events around the world, we are giving back a percentage of the sales we are doing to organizations and to victims associations. So for example, this year we gave a percentage of the sales we've done to Mesothelioma UK to help these associations in its goal to defend victims of asbestos and to find new ways to improve the conditions of asbestos victims and people that have disease related to asbestos. So during the 2 events we organized, one in London and one in Brussels, we have many people from different countries, not only in Europe, but also from Australia, United States and Canada. And this year we started some working group. I mentioned them because we are looking for people that want to participate in different topics to research new subjects and to improve the condition on diverse subjects, for example, digitalization in the asbestos market or the reduction of exposure limit, and to prove how why we have to reduce them and how we could do it. So if you want to join some working group, I invite you to contact me. This year we also visited the European Parliament because I don't know if you are aware of that, but in Europe currently there is a new regulation, or a regulation in discussion at least, to reduce exposure limit for asbestos in Europe, and also to change the analysis method we are using in Europe to make a global regulation for Europe and not only national regulations. So that's why we visited the European Parliament, and we have somebody from the European working group explaining to our visitors what is currently going on during the discussions. And we also have some partnership with national organizations to fight with them to reach asbestos, asbestos eradication around the world. And just to be quick, what is going on in the near future, we are going to organize new events next year and the years after to continue in progressing for asbestos sharing and asbestos knowledge sharing around the world. We also are creating an international laboratory associations to make the laboratory progress on their methods to analyze asbestos and to be more efficient in the way they are doing it. And also we are finalizing the Asbestonomy members directory As I said, it's not a financial organization, it's an open organization to share knowledge and to improve the process. So if you also want to join the directory, I welcome you to do it. We will also be writing positions paper on relevant topics, like the new European regulation. So we really want to improve asbestos knowledge around the world and to help countries to get better management, analysis, and method in their country. So that's why we want to collaborate with many asbestos organizations in the near future around the world.
Thanks very much, Mathilde. I really appreciate your time, and might be able to distill some of the great learnings from the conference for Asbestos Webinar 3.
Yeah.
Thank you for your time. So Tuan Nguyen is our next speaker. He's actually hosting our next session, and so he's actually introducing Sam Lord, Jason Green, and Dr. Hien, from Vietnam. So I might just hand it over to you now, Tuan, then, if that's okay. So Tuan is the president of the US branch, and Tuan is trying to get support for a conference in Vietnam. And as I showed you that flyer to start off with, we'd be really grateful for donations to help move this information and shared learnings forward to Tuan's conference. So over to you, Tuan. Thanks.
Well, good morning, everybody from California. Our next speaker, we're going to have a panel include 3 people: Sam Lord, Dr. Hien Ngo, and Jason Green from Australia. I have a very brief presentation that I would like to share with you. The Faculty of Environmental Sciences in Vietnam, it belongs to the University of Science on Vietnam National University in Hanoi. And we just recently developed an engineering program for occupational safety and environment. And to promote this program, the VNU, or Vietnam National University, going to host an international conference toward the end of October in 2023. And the purpose is to introduce the program and the university to the world. We currently working on a few MOU with university around the world. And we hope that you will join us to support or sponsor this conference. My presentation, I try to keep it really short, but we've been looking at asbestos issue in different point of view, especially in the health hazard. But if you look at the financial issue in the asbestos industry, it's not even $1 billion in export. And Russia total, I think they export about, the Russia Federation probably export about less than $500 million. And one of the main nation that import asbestos is India. And it's about less than $70 million a year in 2021. So if you look at this financial structure, it's less than $1 billion worldwide. And we should not let this industry spread the hazard that and the financial cost in the future that will worth over 10 or $15 billion. So it's a business that we can easily figure out a way to eliminate. For example, if India reduce their import of asbestos from Russia, that will cut the export quantity of the value in Russia from $234 million down to maybe half, including other companies that they join in, like Vietnam or Uzbekistan. So this industry if you look at the financial structure, it can be easily reduced. Okay. And now I would like to introduce Sam Lord. She's going to talk about how Great Britain manages legacy asbestos in non-domestic building. And Sam Lord is the Chartered Occupational Hygienist and the Principal Specialist Inspector at the Health and Safety Executive in Great Britain. Sam is currently the Occupational Hygiene Technical and Strategic Lead for asbestos, providing technical expertise and insight for operational regulatory intervention, civil contingency events, scientific research, engagement, and policy development. So take it over, Sam. Thank you.
Thanks very much, everyone, for inviting me to speak at this webinar. I'm going to, 15 minutes. I'm going to basically talk a little bit about the legacy of asbestos in Great Britain, how that we are managing that to prevent and minimize exposure, and specifically how HSE, as the regulator, how we drive compliance to ensure that the legacy is managed. So firstly, just a few slides sort of reflecting on the asbestos legacy in Great Britain. So this graph here shows how that Great Britain imported around many tons of asbestos, particularly in the 1950s to the 1970s. The graph shows in particular the amosite, the brown asbestos that was imported, and that was used to make insulation boards. And unfortunately, that use there has very much created this peak of mesothelioma deaths since. This graph here is quite interesting in that it shows the mesothelioma mortality rates across the European region, but there's also some other countries such as Australia and the USA. But again, you can see Great Britain in the top right-hand corner does have one of the highest rates. This data is from that period there up until 2012, but I believe it's still the same. So in terms of workplace asbestos exposures, certainly in GB, the past exposures were very much in the manufacture of asbestos products and then the installation of those asbestos products. However, because we've got all that asbestos put into buildings, we still have the legacy of asbestos there, and those buildings need to be repaired, maintained, demolished, refurbished. And that is where we're getting the present day exposures. So we may have uncontrolled removal of asbestos. This picture here shows some asbestos insulation board removed and just bashed down with no controls. That company was prosecuted by HSE this year. Some people inadvertently rip up floorboards. This is a very unusual example, but this is blue, 100% blue chrysidolite asbestos infill lagging underneath the floorboard, and you can see the plumber installing the copper pipe there. The other thing is managing asbestos in buildings. So this here again is an example where a company was prosecuted by HSE, but they just left the asbestos insulation board to deteriorate, and that's not acceptable. So in the UK, we have a set of asbestos regulations which are designed to talk about managing and working with asbestos. They're the control of asbestos regulations. They basically reflect the EU directive at the time. And then supporting those regulations, we have specific pieces of guidance. So we've got the managing asbestos in buildings or premises, how to survey for asbestos, the survey guide. High risk removal work, which I'll talk about shortly, is called the Licensed Contractors Guide. The Analyst Guide, anyone analysing or measuring for asbestos, there's some guidance there. And finally, a task manual for the lower risk work. And again, I'll be talking about that later. And that link up the top there will enable you to access the HSE website and get access to all of those publications for free. So HSE is the regulator for asbestos in buildings, that are factories, construction sites, public buildings, hospitals, schools, farms, and also any sort of manufacturing work. Now, all the asbestos in GB was removed, was banned rather, sorry, in 1999. So we no longer have people manufacturing or using asbestos. But clearly we do need to monitor those activities in those areas. So how do we go about doing that? There's a number of things. Firstly, we engage with stakeholders and we have communication campaigns, and I'm going to show you some examples of those shortly. Our inspectors also inspect certain industries, and we do that on year. We do that because that allows us to keep look for changes or improvements, and also if a lot of places, if they know that they're going to be inspected by HSE, and that potentially will mean enforcement, they will actually drive compliance themselves. So they will make themselves compliant by doing what they should be doing to follow all the guidance. And I should have said earlier, actually, all that guidance and regulation we have, if everyone did abide by that, then we wouldn't have the present exposures. But of course, that's just not the case. And that's why we have to have a regulator and we have to do these things that are pictured on this screen. So ultimately, what we want to get to is more people being compliant, and we call that sustained compliance. So you not only just are compliant for the time that we visit them, they remain compliant and actually improve their compliance over time. And we call that continual improvement. So just quickly, this sort of slide summarizes the key elements to how GB manages asbestos to prevent or minimize exposure. So the first pink box here, all owners of non-domestic buildings are legally required to manage the risk from asbestos, and I'll briefly outline what that involves shortly. Any damaged asbestos in buildings, or that which could at risk of damage, such that it could cause exposure to asbestos fibres, that must be removed or repaired if that is possible. If it's too poorly damaged, then that won't be possible. So it must be removed. Before any major refurbishment or demolish of the building, asbestos must also be removed at that point. There's a slight caveat there, only if it can be done without introducing other risks to health and safety. So say if a building was had a gas explosion or was fire damaged, and that made it physically unsafe for the asbestos to be removed by workers, then it would have to be demolished with the asbestos in place, but controls put in place to make sure that that was done in a way that it didn't spread asbestos, and the waste obviously was disposed of as asbestos waste safely. The blue box down in the left-hand corner here, this is the high risk asbestos. Now this, in the UK, we only permit companies to do that if they hold a license that's issued by ourselves. And again, I'll talk about a little bit about that shortly. And then finally, work on lower risk asbestos materials. Whilst it is lower risk, it still must be completed by trained workers, and they must have a method statement which sets out the control measures. And in GB, we called that non-licensed work. So I'm going to talk a little bit about some of those things further now. So I mentioned duty to manage. This is where you've got asbestos existing in buildings. So the first thing people must do, or owners of the building must do, is identify if they've got asbestos in the building. So if their building is older than, if it was constructed before the year 2000, that's treated as the threshold at which they will have to look to see if they've got asbestos present. And in order to do that, that generally means a competent surveyor must go and investigate the building. Now, a lot of the asbestos is hidden within the building, and it may not be able to be identified until the point that it needs to be refurbished. But they must identify any of the asbestos that is easily accessible by maintenance or the building occupants, because that is at risk of damage potentially. Once they've found the asbestos, they must then identify the risk. All of our asbestos regulation and guidance is risk-based, risk-driven. So not all asbestos presents the same amount of risk, and that depends on the type of a product, but also where it is, And that basically needs that involves a risk assessment, and that's that part of the duty to manage. And once the risk is known, they then can manage the risk, and the main driver is such that no one is exposed, be that occupants or those working on the building. So in order to check that workplaces are doing that, HSE inspectors have been going to places, and this year we went to a series of school buildings. We went to 400 schools, and inspectors obviously looked to see if they were compliant with the regulations, but we also collected some detailed data to look at areas where there was good compliance and areas where there was less sort of weaker compliance. Now, where we get lots of schools not complying with a certain aspect, that generally would be an indication that they might need more guidance or there's a lack of understanding. So that's really helpful in terms of the inspections of the information we can get about compliance and how we can drive that to improve it next time round. And we're going to visit more schools this year. I'm just going to talk about license work with asbestos. This is work, as I've said, with what we call with high risk asbestos containing materials. That's what ACM stands for. So we have asbestos insulation board, sprayed coatings and lagging. They must hold a license issued by the HSE, and they're known as licensed asbestos removal contractors. So again, this will be the full controls that you may be used to. So they'll have the full-faced RPE. They'll work in an enclosure that is under slight negative pressure, so it keeps the contaminated air in. And they must use controlled removal methods, so wetting, shadow vacuuming, and minimizing the breakage of asbestos to reduce the creation of fibrous dusts. They then must go through a decontamination unit to decontaminate themselves, and then the area must also be cleared by an independent analyst who will inspect for any visible signs of dust and debris after the work's been completed, and then they'll issue a certificate of reoccupation. So in the UK last year, most of the asbestos that was removed was this asbestos insulation board, so AIB as we call it. And that relates back to that the graph I showed you earlier, where we imported quite a lot of amosite asbestos, and that was turned into asbestos insulation board in the UK in the 60s and 70s. So that is the predominant asbestos product that's being removed currently, followed by asbestos insulation, and finally a small quantity of asbestos coating. Our inspectors, a different set of inspectors, construction inspectors we call them, they inspect license removal holders, or license holders as we call them. There's 342 currently. Last year they notified 27,000 license removal jobs or work, notified works. And HSE carried out 900 inspections of those works to check again that they're compliant with the regulations and the strict control measures in place. And that is done year on year. Just for completeness, I'll just quickly talk about non-licensed work with asbestos. So this is the asbestos work on lower risk materials such as asbestos cement, textured coatings, and composite materials such as vinyl floor tiles. They must still complete a risk assessment and a plan of work and method statement, and they must put adequate precautions in place and be trained and competent to do that work. And the way we help workers do this is we provide a series of worksheets and that actually specifically talk about specific tasks. So this one, if you can see, is about drilling holes in asbestos insulation board, but we have ones for removing asbestos cement sheets from sheds, drilling through textured coatings. And each of those sheets provides a very sort of step-by-step guide of how they should do it safely, the personal protective equipment that they should be wearing, how to clean up, and how to decontaminate. And the other thing which we want to sort of promote some of our guidance, because there are certainly an age group in this country between about 18 to 34 who might not actually realise what asbestos is and that it still is an issue in our country. So this was a campaign we ran earlier this year called Asbestos and You, targeted at tradespeople. We used very much social media avenues. because that is where everyone has a mobile phone now. They don't look at leaflets or the internet perhaps as much. They'll look at social media. So this campaign was very much aimed at that. It's got its own website. There's the QR code which will access you to that website, and the worksheet essentials were the ones I was just showing you earlier. And finally, the other important thing which we do is we sort of liaise with external stakeholders. So these are people who have other skills or have trade associations, and they also have to help the sort of GB comply and prevent exposure. So again, there's a link here, which is a really useful site, and there's some links to some guides which they have produced, but in conjunction with HSE. And really, certainly those two campaigns and that external stakeholder engagement, this is the message which we're really wanting people to take home, to make sure that anyone, before they carry out any building or refurbishment work, they check to see if asbestos is present. If they're not, they find whether it is, and then they select the right type of contractor that's required, depending on the risk of the work. And that way we can ensure that no one is exposed to asbestos as a result of a work activity in GB. So hopefully that's a quick run through of everything. Thank you very much. If anyone has any questions, there's my email address, and the links will be in my presentation to all that advice. So thank you very much.
Thank you very much, Sam. And
thank you.
We try to catch up, so we have a lot of questions in the chat. But we probably will try to answer, if we have time, we can answer at the end of the session. Thank you.
Thank you. Thank you.
Yeah. And next we have Jason Green. He's the certified occupational hygienist from Australia. Jason holds a master degree in occupational hygiene practice from University of Wollongong. And he also the member of the Indoor Air Quality Association in Australia. Jason is a licensed asbestos assessor and indoor environmental practice and certified water damage restoration technician as well. Jason has over 29 years of experience in the field of occupational hygiene. And Jason is currently the member of the chair of the National Mentoring Program in Australia, Australian Institute of Occupational Hygiene, and he also the current president of the Workplace Health Without Borders in Australia. And Jason, please take over. Thank you.
Thanks, Tuan. Can you see my screen?
Yes.
Yeah, all good, excellent. All right, well, I'll jump into it. I know we're time's a little short, so I'll jump into it. So I've been asked to give a good update and have a look at a brief history of what's happening in Australia with how we came to ban asbestos, and I'm going to have the second part's going to be touching on essentially what are some of the controls and management of how Australia deals with asbestos. So so we essentially started mining asbestos materials in Australia in the 1880s, and similar to a lot of other countries around the world, massive amounts of asbestos was mined in certain countries. Australia was the highest per capita, one of the highest per capita users of asbestos in materials around the world. Jumping to the 1960s, that's when a lot of the studies were getting done, and there was direct links to lung disease and people, particularly asbestos removal and miners contracting these diseases. Later on in the 60s, we eventually looked to ban chrysolite only in Australia. But then moving again on to the 1970s, that's when a lot of the groundswell and a lot of the I suppose building and trade union lobby groups decided to they had enough and realised that we wanted to ban asbestos in Australia. So they lobbied the government. They forced industrial action within workplaces, and they really started to shake things up. Media got involved in that time. The ABC is a government-funded TV channel in Australia. So in the 70s, there was a lot of media happening in that time around the effects of asbestos and how it was a killer in the home. There was a lot of public awareness growing at that time, which the government was slowly starting to become aware of. Moving into the 1980s, amosite was finally banned for its production in Australian materials. Yeah, there was a lot of other sort of groups and advocacy happening around the time as well. The 1980s was also a time when the first claims for compensation were happening in Australia. That's when a lot of the government organisations started to create codes of practice and guides and workplace exposure standards. So 81 was the time when the first occupational exposure standard was brought out, 1 fibres per mil for amosite and chrysotile, and 0.1 fibre per mil for crucidolite. And so there's a lot of really good guides similar to the ones we just heard about from the UK. I'll share these links in the chat for the control of asbestos in the workplace, how to safely remove asbestos in the workplace, as well as the guidance for the filter membrane method. So quickly mention Bernie Banton here. Bernie was a historical asbestos worker working in some of the factories and contracted asbestos exposure diseases, and he was a massive advocate for asbestos within Australia and was pivotal in trying to get that ban happening. So we can see over here there's a union pressure ad that, as well, that was put out in workplaces and things like that. So there was a real heavy sort of groundswell from these unions and other advocacy groups. Moving on to the late 90s, we had the Asbestos Diseases Foundation, who were pushing the government to change the laws. I mentioned about the union involvement there as well. So around the early 2000s was when it finally the government decided to ban all importation of asbestos materials at the end of 2003. So that was an Australian-wide ban, and so those laws were pushed through the states, through all jurisdictions. But yeah, it's coming up to 20 years now, this ban. But unfortunately, we're still, or we're just hitting our peak of asbestos-related diseases within Australia. So there's certainly that lag time from when things are fully banned to when we're seeing this the peak in asbestos-related diseases. So I just want to quickly call out as well the asbestos Safety and Eradication Agency in Australia, which was created in 2013. This had a mandate to prevent asbestos exposure, improve asbestos awareness, and the effectiveness and safe management and removal and disposal of asbestos in Australia. It's been really pivotal in providing general guidance and advice, as well as establishing a national mesothelioma surveillance system and national asbestos profile. So that's really pivotal, so that we know about what's happening throughout the country with regards to baseline scenarios, asbestos consumption, and asbestos-related disease within different states of Australia. So I encourage you to have a look at that website. That'll be in the slides that you'll receive. So the initiatives, I suppose, and some of the ongoing things similar to the UK. I mean, the control has come from all tiers of government, so local, state, and federal governments. So they're all sort of working together, and they all have their own different things that they regulate and assist with how asbestos is controlled. So it's not just for workplaces as well, but there's other non-workplace environmental and public health related controls as well. So these are there as well to assist in the protection of the general public, for example. So I suppose it's we do have these controls that are in place, but I think this ongoing need for awareness and health and safety messaging is really important. And so that's what some of these government organisations are constantly doing, which is great, because I suppose we do still have asbestos materials within buildings. Yeah, obviously we had the first and the second wave of asbestos exposure with the mining and the installation of materials, but now we're sort of seeing the third wave of asbestos exposure for tradespeople and DIY type renovators. And so we want to continue that awareness so that we're not getting a fourth wave of asbestos exposure. So as we heard from our UK counterpart before, I mean, that the ongoing management of asbestos-containing materials is really important. So ongoing surveys, ongoing resurveys and control of asbestos removal contractors are very important. There's another website which is really good, asbestosawareness.com.au, which has some really awesome guides and fact sheets and handbooks. There's also another great initiative for the government, which is asbestos in the home kit, which is really great for residential situations and home renovators, and gives really good guidance there as well. Okay, so just finalising this session now. Just wanted some take-home messages there. The keys to banning asbestos within Australia, it may not work like this in other countries, but it has for us. It really has been the power of the people, the trade unions, these like-minded organisations, such as the Workplace Health Without Borders. There was a pre-planned and well-organised lobbies and to all forms of government and other stakeholders as well. And I suppose collaboration with these associations is really important, particularly the ones that have good reputations and are respected within the asbestos industry. I think the media has played a really great part, as well as social media. I really believe that Australia can be a good test case for other countries around the world. So thank you so much. And a quick plug to one of those associations that are assisting for helping to ban asbestos is the Workplace Health Without Borders. So I recommend that you join. Thank you so much. Thank you, Tuan.
Yeah, thank you, Jason. That's a very great introduction of Australia. It's an eradication agency.
Yes.
Yeah. That's
good.
Yeah.
Yeah. No, it's really great.
Yeah. And our next speaker is Dr. Hiền Ngô. She a lecturer and public health researcher at the Faculty of Health Sciences at Thăng Long University in Hanoi. And her current research focuses on children environmental health, heavy metal exposure, electronic waste, occupational and environmental health risk assessment, mental health, and occupational and environmental health communication and promotion. So Dr. Hiền, go ahead and take over.
Good evening from Hanoi, Vietnam. My name is Hiền Ngô. Today I'm very happy to be here to share with you a brief presentation in the title Asbestos in Vietnam, Current Situation of Using, Waste Handling and Disposal. Also subtitle materials and some legislation related to asbestos in Vietnam. Nowadays, Vietnam is always ranked the 5th in the top 10 countries, mostly in the developing countries, using asbestos, with nearly 20,000 metric tons of asbestos in 2021. And asbestos in Vietnam mostly imported from Russia, China, and Kazakhstan. Among of these, white asbestos or crystallite is common use in the production of roofing sheet and insulation materials under the direction of controlled use in my countries. Among those, around 55 to 80 million square meters of asbestos cement roofing sheet were produced per year in Vietnam. And among the countries, 95% of white asbestos roof sheet are sold in the rural area and ethnic and mountainous area in Vietnam. Besides asbestos, it also used in the other production of gaskets wreck parts for vehicles, shipbuilding, and submarines. According to the Ministry of Construction in 2020, Vietnam is facing with around 10 million tons of asbestos cement, which has become hazardous waste, and this waste may cause a lot of adverse effects on the environmental health and public health issues. According to the Global Burden of Disease study in 2020, Vietnam facing with 2,000 people die from chrysotile asbestos per year, and since 1976, asbestos pneumoconiosis is also considered a compensated occupational disease in my countries, and the worker facing with this disease will be compensated under the government requirements. Among the people facing with asbestos, workers of the roofing factories working in shipbuilding or mining and grinding of asbestos were considered as a higher risk of asbestos exposure, and this may cause the disease related to asbestos when during their workplace, during the time they exposed to the asbestos. According to the Ministry of Labor and Invalid Social Affairs in 2015, more than 80% of asbestos cement roofing enterprise violate of the regulation on occupational safety and health, also environmental management. This will make some cost profit and the disease to the worker working in this enterprise. Regarding the waste handling and disposal, up to date, Vietnam now does not have a qualified asbestos treatment process, technology, or control criteria, and there is no specific regulation or legislation for general waste asbestos collection, classification, transportation, also disposal and handling methods. Up to date, there are some substitute materials of asbestos used in my countries. For example, some other material like PVA fiber, glass fiber, cellulose fiber, ceramic fiber, rock wool fiber, carbon, or other type fiber will be used to replace asbestos using for construction or other production in Vietnam. However, according to one research by Institute of Building Material in 2017, show that the selling price of one square meter of panel using PVA fiber is much higher than the selling price of asbestos fiber cement roofing sheets. Is one of the issues to replace to using other materials replacing asbestos in the production. Also, the investment cost to convert one asbestos cement sheet production technology line to PVA is about 60% of the total new investment cost of the one AC sheet production lines. So this may cause some issue, some challenge to what using the substitute material instead of asbestos in my countries. Up to date, Vietnam have some legislation related to asbestos. According to Circular Number 36, 2015, under Ministry of Natural Resources and Environment in 2015, waste containing asbestos is included in the hazardous waste. However, only waste asbestos, dust, and fiber are regulated as hazardous waste. Besides, other bulk chrysotile is still allowed to be used in the produce some AC sheet in the direction of control use in Vietnam. Other discussed asbestos products such as broken or damaged roofing sheet, asbestos isolation from destroyed boilers, or removed pipe insulation are not included in the list of hazardous waste. It is not that this discussed products may really into the environment and causing some hazardous waste or dangerous to the human and the ecosystem. Right now, the master plan on development of building materials to 2020 with a vision to 2030 will provide in Vietnam to develop a roadmap to gradually reduce to water, ending the use of crystal fiber in the production of roofing material in Vietnam. This is one of the green news for the toward the asbestos ban in the near future in my countries. In conclusion, based on some information, we can see that some research on replacing asbestos fiber with other substitute fiber is significant. However, bio-persistent, inadequate in quality, production cost, investment in substitute materials, also the environmental safety and health of some substitution also need to be considered and studied briefly. And besides, due to the latency periods of development of asbestos related to disease are between 20 to 40 years or sooner, therefore medical surveillance of workers need to be continued during and after employment in the asbestos related industries. This is my shortly presentation of the asbestos in Vietnam. Thank you so much for your attention and
Thank you. Thank you very much, Dr. Hiên. As he pointed out, there are some regulation in Vietnam, but they might have some conflicts. There are loopholes in the regulation, and also they keep delay the ban. And you know, it's supposed to stop in 2020 and then 2024. Now it's 2030. So if we allow the industry to keep on going, it will keep spreading and spreading the asbestos material throughout the world. So the best way to do is to figure out a way to either shut it down or reduce the import rate from other country. So
thank you.
So yeah, thank you very much for the presentation. And I would like to turn it back to Alex or Kevin. Thank you.
We're kind of short on time, so I just hand it back to you then, Alex. Thanks so much for your patience, everybody.
Thank you, everyone. I'm Alec Farker from the International Board of Workplace Health Without Borders. What a great event. We've had even more people attending than our first webinar. I can just see the range of countries and imagine the value of all this information that's been provided so far on prevention. And what we aimed to do was finish this session with a relatively brief panel on advocacy. And due to the time pressure, I'm going to be asking each of our presenters to try to hold their remarks to around 3 minutes. I know it's going to be a tremendous challenge, but if we can't pull it off, then we're going to run out of time. And also we have Eric Jonker from the Belgian asbestos victims group, ABEVA, who will close the event. He was going to show a video, and we're going to share the link to that video, but practically speaking, we won't have time, so he'll be making closing remarks. Hoping we have a little bit of time for questions and discussion, and that depends on how well we do with this panel. So without further ado, I'm going to turn to the panel, and each of them will be addressing 2 questions, obviously more quickly than they would normally, but we'll get started. How can our organizations work more closely towards a global ban? And what do you think can be done to manage the risk of asbestos currently in situ? And we just had our presentation from Vietnam showing the vivid reality of that around the world, and any ideas on that. So in other words, shorter term, what to do to manage risk, shorter term and longer term, which is a global ban. And I'll turn first to Philip Hazelton, who's representing Australian People for Health, Education and Development Abroad, also known as AFEDA. I think what I'll do for each speaker is I will paste their bio into the chat so everyone can see it, but that we won't lose any time. So Philip, who's an incredible incredible, valuable contributor to this cause around the world. You've got 3 minutes to address those questions and get our discussion going, and then we'll just proceed through the panel.
Okay, thank you, Alec. I hope I've got, can you hear me all right?
Yes, fine.
Okay.
Thanks.
Just quickly, I'm from the Australian Trade Union Movement's International Social Justice arm of FIDA, Union Aid Abroad also called. And we've made asbestos disease elimination and asbestos ban in Asia our campaign focus for the last 5 years, but also been working on asbestos bans in Asia, particularly Vietnam, Cambodia, Laos, Indonesia since 2010. You can see there the logo is for the campaign is not here, not anywhere for asbestos. As we've heard already from the motivation, of course, is because we're one of the highest countries in the world in Australia in terms of asbestos-related diseases historically. I'm speaking to you tonight from Indonesia, where we're running a disease conference for university here with the ASEA, which was mentioned before, the Asbestos Safety Eradication Agency, and Asbestos Disease Research Institute in Australia. So we have a lot of people here at the moment helping doctors, oncologists here trying to help diagnose asbestos-related diseases. And I also spent 12 years in Vietnam, just returned to Australia in this last month. So our campaign basically, and I think this relates to mainly the first point in your question, we have been thinking that a global ban is only possible from a number of different angles. So we're trying for national bans in Asia by working with local organizations and trade unions, awareness raising, but also then offering support for what they need in terms of raising awareness in their own countries. Also working with local governments in those countries. We're asked in terms of all aspects of policy advice in regard to eliminating asbestos disease, including the bans. In Australia, we would like to, try to really stop the illegal import of asbestos, seeing we've banned a long time ago, but each year there is still some asbestos coming in. And also work with the Australian Government Agency, ASEA, that was mentioned, to help them in their international part of their work. Globally, of course, we're looking at trying to change the Rotterdam Convention, which we've had a presentation on already. And we've developed with the ACTU, Australian Council of Trade Unions, who facilitate a global alliance of concerned trade unions and NGOs, which is a very broad group, now over 40 organizations that we have been trying to work on reforming that convention to allow block substances for 16 or 18 years now, like chrysotile, to finally get listed. And that listing then has a link to regulation, particularly in developing countries. So I think it's both a campaign that has a national focus, a local bottom-up focus, and also a global focus. And it's also a campaign that seeks to support national bans, but also reduce consumption. So it's awareness raising for consumers. I'll just put there very quickly some of our alliance partners. There's a lot of them. In the region, in Australia and globally. That can be distributed later perhaps. But we are a broad coalition to try and achieve these goals. Some of the challenges that we're facing are, of course, the asbestos lobby, which is fighting tooth and nail against us in all countries where we're operating. We get close to a national ban announcement or a national ban being introduced, and the asbestos lobby will bring out the big guns, including trade threats, to try and stop that happening at the last minute. But obviously there's the other ones as well about limited knowledge about asbestos disease, the long diagnosis and period before it appears, limited capacity to diagnose in most Asian countries, or particularly Southeast Asian countries and South Asia countries. In many countries in Asia, we have a weak advocacy environment as well. It's very difficult for trade unions, NGOs to advocate to government on reform of these sorts of issues. And in many countries, as we've heard, like Vietnam, there's an absence of OSH regulation generally. Some wins, though, recently. This is an interesting one. The Australian Embassy, we work with in a number of countries in Asia. This is a banner on a highway in Vientiane, Laos, put up by the Australian and Canadian embassies jointly with us as a way of promoting in Laos particularly close to the Russian embassy as well. So that's quite interesting. So we can work with government and non-government in this campaign. This was an announcement this month in Cambodia, where the Labour Minister has announced they will stop using asbestos in 2025. We've been working very closely with trade unions, NGOs, and also working with the government Ministry of Labour there on this issue for many years. So that's encouraging, but we're not actually taking too much support yet, because we know the asbestos lobby will fight hard to block that decision as well. And this is the big fight we've had recently on the Rotterdam Convention. We've been with Liam, who's also on this webinar, who facilitates this group. I've been working for 4 years to try to work with like-minded governments to reform the Rotterdam Convention to stop the blocking of chemicals for self-gain for those small number of countries that can block. And we got very close. We have an alliance of more than 40 organizations, broad both in every region of the world, but also trade unions, national, regional, global, as well as NGOs, particularly the pesticide interest groups. So this is it's a really strong coalition that we will continue to work with and see where we can go for that in the future. We are obviously, the Rotterdam Convention, as we've heard, is not a brilliant convention, but there's not much else globally that is available in terms of a global ban effort. While the convention itself is not a ban, it is an information exchange mechanism and does have links directly to many developing countries where a chemical is listed, it triggers inflation in a lot of countries. So a lot of the campaign restrictions we find at national level in Asia, people say, or governments say, it's not registered on Rotterdam, so why should we ban it? And of course, they understand why it's not registered as well. But so this is one of the prongs of attack that we need to really succeed in reforming this convention, I think, to facilitate more broad national bans and finally achieve a global ban. Thank you.
Thanks very much, Philip. And we'll move immediately to Sugio Furia from the Ban Asbestos Network and from Japan. And I'll put Sugio's bio in the chat as well. So take it away, Sugio, and see if you can make it happen in 3 to 4 minutes.
Good evening from Japan. My name is Sugio Furia, coordinator of Asian Ban Asbestos Network. The trend of global asbestos consumption. According to USGS data, annual global asbestos consumption is still more than 1 million tons. And the share of Asia and the Middle East is steadily increasing and now accounts for almost 80% of global asbestos consumption. Recently, #1 country is changed from China to India, followed by Russia and Indonesia, Russia, and Uzbekistan. Other top 10 countries are Sri Lanka, Vietnam, Thailand, Bangladesh, and Kazakhstan. Asia is becoming a last resort for global asbestos industry. In other words, the main battlefield against asbestos industry for achieving a total ban on asbestos. Asian Ban Asbestos Network was established in 2009 at the second Asian Asbestos Conference in Thailand. It was a result of various efforts by different groups. As occupational victims groups network in Asia and the regional trade union asbestos campaign are two mothers of ABAN. Global Asbestos Congress was held in Brazil in 2000 for first time, and the second GAC was held in Tokyo, Japan in 2004. The first Asian Asbestos Conference is held in Thailand in 2006. After establishment of Asian Ban Asbestos Network, based on the experiences in Japan and other countries, we have been facilitating coalition building and the empowerment of asbestos victims and their families. So far, ban-asbestos networks have been established in 10 countries: Japan, Korea, Hong Kong, Indonesia, Thailand, Bangladesh, Vietnam, Cambodia, Laos, and India. So occupational hygienists in those countries can join and work together for achieving a total ban on asbestos. Yes, asbestos-related diseases is still invisible in many Asian countries. In some Asian countries, there have been no asbestos cases recognized as occupational disease yet. However, asbestos victims groups exist in Japan, Korea, India, and Indonesia. Occupational victims groups in Hong Kong and Taiwan are supporting asbestos victims and their families. And other than national and regional campaign, ABAN has been involving in international activities. In 2010, ABAN has Asian Solidarity Delegation to Quebec, Canada, to stop reopening of closed asbestos mine for exporting asbestos to Asia. And I think we finally won this battle. In 2019, ABAN has sent its mission to Brazil to stop asbestos export to Asia and acted with a wide range of Brazilian colleagues. Finally, Brazilian Supreme Court seems to make decision on this issue. Also, ABAN has sent asbestos victims from Indonesia and India.
Sukio, Sukio, your slides aren't changing. That's being noted by people.
This one? No?
It's still showing the first slide. If that's your intention, we've only got another minute or so.
Wow. I don't know why. Okay.
We'll be sharing all the presentations later.
Yes, or that's right.
There we go.
Okay, so
and there's Sugio, there's 1 minute left.
Yeah, okay. Has sent asbestos victims from Indonesia and India to COPs of Rotterdam Convention in 2015, 2017, 2019, and 2012. We couldn't send asbestos victims for COP11 in this year, but we have organized the ABAN conference in Bangkok, Thailand on May 7th. The first time for the past 4 years face-to-face meeting. The contents of the conference are listed here. And as Philip introduced, Cambodian government, Cambodian Ministry of Labor announced its intention to introduce a ban on asbestos. I'm expecting to let you know more good news from Asia in the very near future. So anyway, I'd like to ask occupational hygienists in the world to consider how to contribute to achieve a ban on asbestos in your country and globally. Thank you very much.
Thanks very much, Sukio. As everyone can see, we're trying to join those two worlds of advocacy and then the many, many occupational health and safety professionals who are participating in this webinar today. And we have a great privilege of having one of the leading occupational hygienists in the world with us next to speak. It's Samantha Connell, the president-elect of the International Association of Occupational Hygienists. So I'll turn it over to Samantha and I'll put your bio in the chat. And somehow you have to get your message across in about 3 to 4 minutes. And then we have Eden. He might be commenting, he's coming next. And there's been a question in the chat on the lack of data on Africa, and that is a really big issue. So we'll go from Samantha to Ehi, and I'm watching to make sure that Eric Jonker has joined us. Hopefully he will. So Samantha, and if you have trouble sharing, let's make sure that she can share her slides.
Hi, thanks, Alec. I just plan to speak a little bit, especially since I only have 3 minutes.
Okay.
All right, thank you everyone for having me. I'm representing IOHA today, the International Occupational Hygiene Association. And maybe just to give a little bit of background, we have 41 member organizations. So we're kind of an association of organizations. And across those, we have over 20,000 individual members, if you will. And so in thinking about how we can get the occupational hygienists more involved in this, I hope you'll reach out to us also to be a part of that. So our main role, I guess, so far, it's not that we've necessarily contributed technically to much to do with asbestos, but we have been educating occupational hygienists on these issues, and we've also made sure that our profession as a whole has been recognized. You know, that people know to call an occupational hygienist and where to find one. I think we do have a huge opportunity to find out, you know, what our member associations are doing in this area, and, you know, across those maybe 20,000 individuals out there, where are people that are already involved? How can they contribute? Do they have expertise that they can share with you all? So I hope that we can help you connect with them there. And you know, as a whole, being able to reduce the burden of this occupational disease in our environment. I think also last year we did have an educational session. We had several of our members from Australia and New Zealand present on an IOHA webinar on asbestos, where they talked about you know, the importance of best practices and presented several case studies that they shared. They spoke on the importance of good planning and management to mitigate the risk, and then also on the mixed hazards and renovation and demolition. We also, as an organization, you heard Asbestonomy spoke earlier, so we've signed an MOU with them in recent years, and we're looking to collaborate on, you know, the communication aspect, on sharing the education and information that's out there. And so, yeah, that's what I would like to offer you all today. Please, we will be in touch as well with the WHWB working group. And we hope also that you'll reach out if we can help you with anything, or help you find members or organizations out there that can support.
Thank you so much, Samantha. It's such a powerful collaboration that we're striving to establish, and your contribution is extremely important. And we're looking forward to a lot more in future, because the moment has come, I think, when around the world, so many people can see that we have to put an end to this. And of course, there'll be lessons learned from asbestos for many other workplace exposures. So now I'm going to turn to Ehi Eden from OSH Africa. And we have already had some questions about Africa. And of course, it's a major place for concern about exposure to asbestos, and especially often the lack of resources to deal with it. I'll put Ehi's bio in the chat, and take it away, Ehi. And somehow you have to do yours in 4 minutes, which will leave 5 minutes for Eric Jonker to close the event.
Thank you so much, Alec, and thank you for everyone for such a wonderful value presented. But the truth is, the question we're asking, does Africa have asbestos? Yes. Africa has 54 countries, as you are aware of, but sadly, only 47 of these countries have national asbestos legislation. And this is where the problem is hinged. And we are aware that asbestos thrives higher in Southern African region, where you have high level of mining activities. And countries topping the list in this sub-region are South Africa, Botswana, Zimbabwe, and Malawi. If you are here today, you're wearing either gold or diamond, understand the fact that somebody got exposed to asbestos in an attempt to go to mine site to seek those things that we are all wearing. So in a nutshell, the less we wear of this also, the more we also help those who are involved in daily mining of this asbestos. Countries with asbestos legislations in Africa are just about 7. We have South Africa, we have Mozambique, we have Gabon, we have Djibouti, we have Mauritius, we have Algeria, and Egypt. And this is sad that we have, amongst all the countries we have, only these countries have indeed signed in asbestos legislation, and it's a big issue we are grappling with. Then these are left up with so much challenge, because in Africa, asbestos is still something that is like the elephant in the room that nobody wants to touch, yet the elephant exists. We have a lot of challenges, I mean, within the asbestos framework. We have information gap and insignificant data to support asbestos in Africa that are still very significant. We have, like I said earlier on, we have the absence of asbestos legislation. So if there's no legislation, we can't control what happens within the space of asbestos at country and at regional level. Again, in countries and in the region, we have what you call prioritization of economic gains at a huge human cost. And this is what we have. We want to create employment in Africa, but we create those employment at a huge human cost, which of course, one of them is huge exposure or undue exposure to asbestos risk on a daily basis. Then we have the presence of old buildings where asbestos exposures happen. I remember while growing up, we lived, the building that close to us that were built by government where my father was teaching, and these buildings were all roofed by asbestos. And these buildings are getting old right now. Pulling these buildings down have become issues. How do you pull these buildings down without people getting exposed to asbestos? How do you manage people that have lived in these buildings all their lifetime? Because asbestos exposure doesn't come with instantaneous health effect. The cumulative health risk due to the past exposure, how do we manage them when they start manifesting? These are some of the questions we will be asking. We also have poor management of demolition of these old buildings, because if you must demolish these old buildings, how do you ensure that there's no asbestos in the air? I mean, which of course, no matter how minute the exposure limit may be, how do you handle the remnants, the waste that you generate from this demolition? These are key issues. If you must move or transport these roofing sheets, where do you move them to that is safe? I mean, enough for people to inhabit. These are some of the clear questions we are having. Then we also have issues of gross inertia on the part of regional leaders. Most of the leaders we have in the region, everybody is quiet. It looks like we live in an asbestos-free region. No, but asbestos exists, but we have not had leaders that are bold enough to make legislation and make this work. What are the outcomes, possible outcomes of these challenges? We have increased rates of asbestosis, lung cancer disease, and mesothelioma in communities and sub-regions where exposure is so high. Then we also have increased healthcare utilization as a result of cumulative health effects of asbestos exposure. Then we have increased population of people that are not able to contribute optimally to the national economy as a result of asbestos-related diseases. They are not well and they keep managing themselves to and from hospitals, so they find it difficult to contribute to the economy of their country. Then we have the Zimbabwe shocker, in 2019, where we had asbestos sites that were closed, many sites that were closed, were being reopened for asbestos production by Shebani and Mashawa for asbestos production in 2019. And this is a mystery. We still don't understand how it happened. Yes, again, economic gains, because the sites go produce about 140,000 tons of asbestos annually, with employment opportunity of 300,000 jobs for the nation. You can see the human cost, because we want to create employment for people, and we prioritize the economy over the health outcome. But when the health outcome starts showing up, we can't manage it. Even what we gain economically, we lose them through healthcare consumables. What are we doing?
So, Ehi, we've got to wrap in about 1 minute.
That's fine. We are building and building capacity in Africa. We are setting up what you call Africa Asbestos Prevention and Control Network. This is very new in our table. Advocacy for asbestos risk and ensuring high information on asbestos are made available in areas where they are needed. And we're also engaging regional and national leaders for asbestos legislation and prohibition. And we're also setting those partnerships on this. We also have a program we are trying to flag up with Makerere University in Uganda to see how we can train people on asbestos management, control, and handling. So this is the African one that we are building, and thank you so much for listening.
Thank you so much, Ehi. I've gotten to know Ehi over the last couple of years through our international collaboration with Workplace Health Without Borders. You're having a tremendous impact, not just in Africa, but around the world. And I think people can see the power of collaboration on a global level. A couple of things before we get to Arik. We're going to go past 9:30 for anyone who can stay, and we'll try to address as many of the questions as possible that haven't been addressed so far. So anyone who can stay past 9:30, that will be fine. We'll certainly go on for at least another 15 minutes. And secondly, please don't forget about our third webinar, which is Wednesday, July 12th, the same time, 7 o'clock Eastern time. That's our effort to include the whole world, although it's very early on the west coast of North and South America. And please don't forget about the Vietnam conference upcoming and the chance to contribute. We'll be distributing further information on that coming up. And without further ado, I'll turn to Eric Jonker to close the event. Eric's bio, you'll see in a moment. He's a friend. He's a longtime colleague. Eric is a very brave human being who's faced things that really no one should be expected to face, and has been a steadfast champion for banning asbestos around the world. And I have hosted him in my own community on a couple of occasions with great pleasure. So I'll hand you over to Eric Jonker.
Are we there? Are we connected? So I understand we are running out of time and the video cannot be shown, correct?
That's right.
All right.
We put the link in the chat. People can view
All right,
it
very good.
in the link. Yeah.
So yes, hello everyone. My name is Eric Jonker and I come from Belgium, the country that has seen the largest asbestos cement factories in the world, Etex Eternit. I also happen to preside ABEVA, the Belgian Asbestos Victim Group. For over a century, we have known about the risk from asbestos, both to workers and to community members from secondhand and environmental exposures. This remains by far the major killer of workers worldwide. Although progress has been made towards a global ban, asbestos used in many countries, and even in countries where asbestos has been banned. Prevention measures are still inefficient to protect millions of workers, students, teachers, firemen exposed to legacy asbestos. For many people, numbers, data, scientific languages, all just sail past them. But the human experience of suffering gets their attention and engage the best of them. Let me remind you that over 300,000 lives are lost every year due to asbestos exposure. In court, Eternit Belgium claimed the case of family Jonkers was isolated and was due to the negligence of our father Pierre, returning home with his clothes tainted with asbestos fibers. Wouldn't you agree? This is stinking. When we began our family struggle in court, the forces that raged against us were powerful, including the fact that we were a French-speaking family in an area dominated by the Dutch language. 23 years after her death, I'm still very proud of my mother, Françoise, who refused to accept the hush money that would have forced her to remain quiet. That's why, so far, she's the first one and the only one to have taken Eternit to court and won. How many total deaths related to asbestos in our area? How many workers and non-occupational victims everywhere around the world? The numbers keep growing while pro-asbestos lobby still deny any wrongdoing. We know some workers suffering from asbestos-related disease refuse to believe the source of their illness would come from the factory. That shows how bad entire villages or workers' union are under the influence of strong fake messages from transnational corporation or government. Some victims loyal to Eternit just refuse to submit their case to the AFA, the Belgian Asbestos Fund that provides financial help to persons falling ill due to asbestos. They just refuse to acknowledge the fibers they have inhaled at the plant might have been the source of their asbestosis or cancer. What concerns us today is the rise of non-occupational victims of asbestos. These men and women often inhale asbestos without their knowledge. The story of my family is a simple story. My father worked at the plant and died in 1997. My mother, housewife, died in 2000. then Stéphane and Pierre-Paul. Two of my brothers died at age 44. I come from a family that chose to trust the reassuring message from a paternalistic industrial family sense. In the post-war years, their good words was a prerogative of the leaders. We know now how much pro-asbestos lobbies have lied and continues to lie. When big money is at stake, there is no humanity. The health of their wallets took precedence over what the health of the workers. Speaking out on behalf of the voiceless victims has become a real driving force for me. After 4 deaths in my family had to deplore, I wanted to invest myself more in the messages of prevention, point the finger towards multinationals responsible for spreading fake news and pursue the quest of justice. Not only in Europe, but also in countries where asbestos is still being used and processed and produced. Workers and population in countries in the process of development must be able to benefit from the social and medical progress accomplished elsewhere. A transnational company who leaves and sells their factories in Asia or Africa must be accountable for the mess they leave behind. They must bear the cost of cleanup. Since I started by traveling as an activist, I've seen enough locations overseas, in Carmo, India, Kinshasa in Congo, or in the Canadian province of Quebec. They all look like the site I used to play in as a child in Capelle in the 60s. In 2023, I can no longer be morable accept that children play on dump site and put their health at risk because local governments are unable or unwilling to enforce cleanup. All over the planet, everyone deserves a quality of life, decent wage. Life does not wait and can never be replaced. I will never forget the faces of those victims I had the honor to accompany until their last breath. The Victim Association must become, if not already, an essential relay for dehumanization of the care and the delivering of the bad news once asbestos strikes. When the life of the victim is ended, their story continues. We must talk about the dead, talk about their life and struggle, remember their joy, their sometimes short passage on planet Earth. We must speak of them because to keep their names silent is to make them die a second time. Now, ladies and gentlemen, I must reveal that the video that should be shown that was taped 2 years ago is no longer up to date. A blue dot is missing, the one that bears my name. My wonderful years as kid in Capelle ended 42 years ago. For 27 of them, I covered and discovered many countries under control of a mighty Boeing 747. Today, I've become patient in all the sense of the word. On February 4th, 2021, I was diagnosed with the same cancer that took the 4th life in my family. Being thrown from being an activist in the public eye to the other side of the fence as a victim with a bleak future is something I do not wish to anyone. The discovery of the meso has redistributed the cards. Everything has been turned upside down. I very quickly chose to be operated to remove the affected pleura. Then radio, followed by chemotherapy. Sadly, my good health has been stolen forever. I have begun a new work, the task of mourning, to mourn my health, to mourn the abrupt end of my career, mourn of being an active optimist. I have to live with this new diagnosis and imagine a new life. So I will not talk about the lack of life, but also point the finger towards the darker side of an industry that generates huge profit on the back of workers and the public. We need a system of justice that punishes multinationals that have, in their past, or still produce asbestos today. In France, employee may successfully prosecute their employer if the latter has committed a gross negligence. Sadly, in the new court action, I have initiated against Eternit, my lawyers and myself will have to demonstrate that my exposure leading to my cancer would be classified as willful misconduct. We need medical breakthrough. We need strong, organized, sustainable victim groups that speak for the voiceless workers. Our struggle would not be successful without inputs from activists or lawyers from Belgium and beyond. If we want to steer towards a global ban and hope for a powerful global movement, solidarity is paramount amongst victim association allies. In an effort to provide needed information, some step forward sometime in their darkest and most difficult ways. Let's take an example. If your favorite Italian restaurant is caught using dog food in his spaghetti sauce, the owner will face the closure of his establishment and risk to pay a hefty fine. Agree? In the case of asbestos, Eternit was found using all kinds of asbestos for many, many years, even though they knew and they had lied about the danger that the life they would put on in the population around the factories. These executives never were forced to close the factory, nor spend time beyond bar, or have to pay hefty fines. Both are true stories. After our tears, we do not need pity, we need action. And action will lead towards winning. It's a question of when and how. It's a question of justice. Before I close, let me mention that there is hope. On June 7 in Casale Monferrato in Italy, they celebrate a great day in their struggle for justice. When an Italian court found Eternit executive criminally responsible for the death of many community members and workers in their region. The activists in Casale had faced many setbacks in their struggle for justice, but they never gave up. They persevered, and the perpetrator has been held accountable. It is important to remember that there is no minimum threshold of exposure to asbestos. I urge you all to think big and frame your own country's struggle in the perspective of a global man. We must unite to expose the danger of asbestos. Polluters must become the payers. After the brutal murder of his wife, a Belgian poet, Julius Bocard, wrote, "You have to eat a bag of coal if you want to hope for heaven." Thank you for your kind attention.
Thank you, Eric. This means a tremendous amount. I'm sure everyone's experiencing the same emotions that I am. And I think you should know people like you, stories like that of your family, they do inspire the professionals to do their very best to make a difference. I should tell everyone here that when Eric visited in 2012 to Canada, he told me some of the asbestos in my lungs is from your country. And he, in fact, had the opportunity to visit and see these mountains of tailings left over from that extraction. And I think little did we know how it would all play out in the years to come. You're seeing a courageous person. You're seeing someone who's facing what millions of people have faced, which is mesothelioma. And all for an industry that is now at the $1 billion level. It is an extraordinarily ridiculous in some ways, if we'll use dark humor, situation. So thank you, Eric, for everything you have done and everything you're going to be doing and the life that you're living right now. Eric's a person full of joy, full of life, and a precious person in our world. So I know there are people that have to go. Anyone who can stay, please feel free to stay. I'm going to hand things over, I think, to Marianne or Kevin to chair the question and answer. And we'll stay. We can certainly stay for another 15, 20 minutes and deal with some questions. There's some really important questions in the chat. So anyone who can stay, please do so, but don't feel bad if you have to leave.
There were several questions about asbestos in Africa and where I remember one that was where is the asbestos located? Is it in residential buildings or institutional buildings, or probably both? Do you want to speak to that?
Thank you so much. We have asbestos in even in most government facilities. We still have asbestos being used. If you have read about the Seychelles controversy, where Seychelles actually had banned asbestos years ago, but all of a sudden asbestos were imported to build facilities that's going to house almost about 90% of citizens in that country. So you understand how that is. So if you go to most residential properties in some areas in Africa, you still see asbestos has been used. Like I mentioned earlier on, when my father was teaching in a school, I was just about 10 years old or thereabout. The houses that were next to us built by government, they were all built with asbestos roofing sheets. And these are some of the issues we have. Not just the roofing sheets alone. Understand the fact that asbestos is also found in some of the automobiles that we drive. I mean, look at the brake pad, the gaskets, and these are things that asbestos they are made out of asbestos. So when we look at asbestos as issues that have to do with construction of buildings alone, we might not just be approaching it from the right perspective. Automobiles and other things that we use on a daily basis have some components of asbestos, and I think this is where the conversation must be hinged. That, like, back to your questions, both public buildings and individual buildings in across many countries in Africa, we still have asbestos. At that time, asbestos roofing sheet was cheaper and was more trendy than the corrugated roofing sheet. And most of us then we used to take rainwater that comes from the asbestos sheets. You see children having those rainwater they gathered from the asbestos roofing sheet from homes. They used to have their baths. So now, knowing what I know in asbestos right now, I just imagine in about 10 decades to come, what will happen to those children based on this exposure? And these are the questions that is bothering most of us. Thank you.
Can I just sort of say something too? There's somebody who's put other funds available for people who want to do research on asbestos in masters and PhD level. We need more study in South Africa. We do have somebody on the board of directors, Claudina Neguera from South Africa, and we're kind of, we try and help. We try and join the dots and connect people. But just on the point of, asbestos cement material, we're kind of organizing our next webinar on the 12th of July. And we do have somebody from Curtin University talking about a phone app that they developed where you can actually look at asbestos cement material sheeting, and you can actually do a risk ranking using this phone app. So you can look, you're doing an inspection and look at how badly deteriorated it is, and then kind of put a plan of action based on the risk ranking using this mobile phone. Most people have mobile phones around the world, and they'll be able to download this. So that's on the 12th of July. Thanks.
And Ebenezer has his hand up. Ebenezer, please, you can unmute.
Right. Thank you very much, Marianne. My question is mostly directed to Ehi Eden, since he's working mostly in Africa. I find that as individual countries in Africa, most of us being developing and mostly reliant on things like asbestos, has there been any effort to look at region-wide agreements to ban the import of asbestos to present a much more stronger economic front? For instance, the way the European Union has a ban on asbestos or a certain environmental bans. Has there been a region-wide ban, let's say Africa Union banning, so that we can have a stronger front in dealing with these things?
I got you, Vendetta. Thank you so much. If you followed the paper as presented by Tuan, you find out that Angola, Gambia, South Africa, and Ethiopia are still topping the list of the countries that still import asbestos in Africa. Why there has been agitation, advocacy, education from non-government actors on the outright ban on asbestos, but sadly we haven't seen this kind of zeal that would require from the African Union to speak to issues that as it concerns asbestos. Like I made mention of in my presentation, when we have leaders of government who places priorities on economic gains over the huge human cost, this is a problem. So we are pushing in partnership with African Union Development Agency to see how we can get government attention to this area. But as today, there has been no such action from the regional government. That was why I mentioned in my slide that the inertia, which means the inactivity from regional government and government at country level, is a big issue. But yeah, it's huge, but it's surmountable. Just keep pushing and engaging these people. Thank you.
Thank you.
I just want to say also, there's been a lot of questions come through on the, the logistics about, managing asbestos in buildings. And Jason Hodgkiss has been kind of answering a lot of the questions as they come up. Jason's actually he's an important part of our working group, important team member in our working group, asbestos working group. And Jason's actually going to be presenting also on our webinar on the 12th of July. So, and that's kind of also going to involve, risk assessment, risk management. So a lot of this can carry over to that webinar as well.
And I see there's a question in the chat from Newton, but Newton, you asked about a bilateral collaboration between the two. I'm not sure between which two. Can you unmute Newton and ask your question? Or maybe Ehi, or you can speak to that. Oh, there you go, Newton. Yeah, go ahead.
Okay, I think Mr. Ehi has touched a little bit of it, but it's just a concern I'm trying to express. When we have the problem of asbestos usage, much more in Africa, has been outlined by Ehi and others. But my concern about this is that Africa does not produce most of these, asbestos-bearing materials. Let's say, for instance, roofing. Even if they produce, the importation of raw materials come from outside. Now, that is why I'm looking at, comes to the safety bodies we have all over, the international bodies organizing this, but how can we make collaborations with the West and other places, that is intercontinental collaborations that will ensure that this is reduced to the barest minimum. Yes, banning the importation on the part of African continent is very important. But again, it's a trade itself that has its own kind of way of sustaining itself. So if I don't want to trade, there may be somewhere someone else wants to see that he trades whatever product he has to ensure that it gets to a market that is cheap enough for me, available for him to get these things disposed. So we need to look at all this and see how we can strike a balance. Thank you very much.
Thank you so much, Newton. That's very on point. I think if you listen to Marcos Orellana presentation, he talked about shared responsibility and right of information. I think we need to start having those regional collaboration right now, and we need to, because the truth is that there is no corruptee without a corruptor. It's a two-way thing. We need to start. Regions should start conversation and start sharing information. Along these lines, because where the asbestos really come from, there are rulers in those countries. So once we start sharing information and having collaboration, you find out that this will greatly reduce, though I know that most times economic interests superintend over the interest of public health. But I think the good point to start is start sharing information and having this collaboration where we can start having these restrictions and prohibitions. It won't be a bad idea. Thank you so much, Newton. I appreciate that.
So we're almost at the top of the hour. I think probably we need to stop soon, unless there's one more question that someone wants to ask verbally. I think we would have time for that. If not, perhaps Kevin and Alec, you could say our thanks.
I'll say thank you before Alec. Alec's spearheading the three sessions, but I kind of helped host and lead this one from the start. I just really am grateful to all the speakers, and especially to you, Eric, to come in on the end and provide your story with us all. So I want to put out a special thanks to you for sharing your story and doing the great work you're doing. We're all behind you. That's all I can say. So over to you, Alec.
So thank you, everyone. I'm hoping that you're seeing the power of what global collaboration can be like. We scheduled this event, as people will notice, so that we could have it as convenient as possible in the parts of the world most affected, and yet include the whole globe. So I especially want to thank people like Tuan Nguyen, who got up at 3:30 this morning in California time to be able to participate. Never a complaint, and he's been just such an important collaborator in all of this. And then to everyone who presented today, there's so much work to be done. Back early in my career, I never would have thought that in 2023, we'd still be dealing with asbestos and also still dealing with active use, not just the legacy. It's an extraordinary, sad commentary on the economics of the world we live in. And we're going to do something about that. As you can see, there's a lot of potential. There were several questions in the chat we didn't get a chance to get to in enough detail about international collaboration and what can be done in a country that may lack resources, what kind of support might be available. I want to assure everyone, with those thoughts on your mind, that we are committed to making that collaboration happen. We're obviously a voluntary organization, but it means we're nimble, creative, and capable of mobilizing a lot of experienced volunteers. So if you're from a country that is struggling with this issue, please don't think it's just one webinar we're holding. Workplace Health Without Borders is here for that kind of collaboration. That is why we exist. And we'll do everything we can. The next webinar will be more technically oriented, but I think very valuable, especially to those at the front line in identifying and risk assessing asbestos. So it's Wednesday, July 12th, same time. I earlier posted the registration information, and it's freely available. We'll be distributing it again. And we're looking at other webinars. We're not totally sure which ones they'll be. There might be a global asbestos advocacy one that lets us go in more detail on those issues. There might very well be one about something suggested by Bernie Fontaine, one of our WHWB folks, about asbestos exposure from human-made and natural disasters. Lots of work to be done. And also the Vietnam conference, which the planning is progressing, and we're going to be hoping that some of you will contribute financially to support that conference, and we'll be distributing more information about that. Hoping some of you will be able to come, at least virtually. So thank you, everybody. Thank you for giving so much of your day to us. So many have stayed. There's still over 100 people here. That's showing how much you care, how much you're committed. And let's carry that forward in the days, weeks, and months to come. Thank you, everybody.